Welcome to AETCM EM Rapid 2022. Today we'll be discussing about burns and compartment syndrome. So the skin consists of two layers. There is epidermis and the dermis. And the skin thickness varies by both age and anatomic location. It is relatively thinner at the extremes of age and also thicker on the palms, soles and upper back. So therefore the depth and severity of thermal injury can vary both by the age of the victim and also the anatomic location where it was exposed. And the skin functions as a semi-permeable membrane to evaporate water loss and also protects against environmental assault. And also it aids in the control of body temperature, sensation and also excretion. Partial thickness burns can disrupt these barrier functions and contribute to free water deficit. And this deficit may be significant with moderate to large burns. Thermal injury can result in a spectrum of local and systemic homeostatic disorders that can contribute to thermal shock. And this includes the disruption of normal cell membrane function, hormonal alterations, acid-base disturbance, hemodynamic changes and also hematological derangements. And the fluid and electrolyte abnormalities seen in burn shock are relatively the result of alterations of the cell membrane potential, causing intracellular influx of water and sodium and also the extracellular migration of potassium secondary to the dysfunction of the sodium pump. And the thermal injury is progressive. The local effects of injury can include the liberation of vasoactive substances and also disruption of cellular function and formation of edema. The subsequent systemic response can alter the neurohormonal axis and further extend the injury. And implicated in these events are histamine, kinin, serotonin, hyaluronic acid metabolites and free radicals of oxygen. And these substances exert their primary effects at the level of a local level and also cause progression of the burn wound. And although there are many factors that influence the prognosis, the severity of the burn, the presence of the inhalation injury, are also associated injuries, and the patient's age, comorbid conditions, and also any acute organ system failure are the most determining factors of prognosis. And cell damage can occur at temperatures above 45 degrees Celsius or 113 Fahrenheit, owing to denaturation of cellular protein. And the size and depth of the resulting burn are functions of the burning agent, its temperature, and also the duration of exposure. So pathophysiology, the burn wounds are described as having three zones. There is a zone of hyperemia in which there is increased blood flow. And the second is the zone of stasis in which there is stagnation of the microcirculation, and it can progressively become more hypoxemic and ischemic if the resuscitation is not adequate. So at the level of hyperemia, if there is we are giving adequate fluid resuscitation, it can actually promote to spontaneous recovery. And if there is not enough adequate fluid resuscitation, it can go into more hypoxemic and resulting in coagulation. And finally, the stage of coagulation in which the tissue is irreversibly destroyed with thrombosis of blood vessels. The burn size determines the fluid resuscitation needs and also the majority of decisions for hospital transfer. And the burn injury size is quantified as the percentage of body surface area involved. The most commonly used one is the rule of 9. It is a very simple and commonly used method to calculate the burn size, and it divides the body into segments that are approximately 9% or multiples of 9%, and with the perineum forming the remaining 1%. So there are 11 times 9% along with perineum with 1%, overall forming 100%. And because of the proportionally larger head and the smaller legs of infant and children, this method must be modified in pediatric burn injury, for which we have two other methods. And one is the Palmer's method using the hand of the patient. So the area of the back of the patient's hand is taken as approximately 1% of their total body surface area. And the number of hands can equal to the area of the burn can give an approximate value of the percentage of body surface area that is burned. And a third and a more precise method uses the Lung-Brownler burn diagram, and this allows an accurate age-adjusted determination of the burn size for a given depth, allowing for the anatomical differences in children. So coming to burn depth, the depth of the burn has been historically classified as first degree, second degree, third and fourth degree. However, a classification of burn depth according to the need for surgical intervention has become the newly accepted approach, especially in burn centers. So it is mainly like superficial, then superficial partial thickness, deep partial thickness and full thickness burns. So a superficial burn involves only the epidermal layer of the skin, and a sunburn is frequently given as an example, even though it is caused by ultraviolet light instead of thermal injury. The burned skin will appear to be red, painful, and tender without any blister formation. The superficial burns usually heal in about 7 days without any scarring and usually require only symptomatic treatment. And next we have the partial thickness burns, which can extend from the up to the dermis and are subdivided into two types, that is superficial partial thickness and also deep partial thickness burns. In superficial partial thickness, the epidermis and the superficial dermis, including the papillary layer, are injured, and while the deeper layers of the dermis, including the hair follicles and the sweat glands and the sebaceous glands, are spared. So superficial partial thickness burns are often caused by incidents like hot water scalding, and the skin will appear blistered, and then also the exposed dermis is red and moist, and these wounds are extremely painful to touch. The dermis is well perfused and with intact capillary refill. These wounds usually heal typically within about 14 to 21 days, and the scarring is usually minimal, and there is almost full return of function. And coming to the deep partial thickness burns, it can extend up to the deep level of dermis, that is the reticular layer. And hair follicles and sweat glands and also sebaceous glands are sometimes damaged, and their deeper portions may usually survive. Hot liquids like oil or grease, steam or flame usually cause this kind of injury. The skin may be blistered and the exposed dermis is pale white to yellow in color, and the burned area does not blanch. It has absent capillary refill and also absent pain sensation. Therefore, the deep partial thickness burns may be difficult to distinguish from full thickness burns, and the healing will take 3 weeks to 2 months or even more. And also, the scarring is common and also related to the depth of the injury. The scarring can even be more. Surgical debridement and also skin grafting may be necessary to obtain maximum function. And next, we have the full thickness burns, which involve the entire thickness of the skin. And all epidermal and dermal structures are destroyed, and these injuries are typically caused by flame, hot oil, steam, or contact with any hot object. And the skin is charred, pale, painless, and also leathery. And because all dermal elements are destroyed, this injury does not heal spontaneously. And surgical repair and skin grafting are necessary, and also significant scarring is in the norm. And 4th-degree burns are those that extend up to from skin to subcutaneous fat, muscles, and even the bone. And these are devastating, life-threatening injuries, and amputation or excessive reconstructions are sometimes required. Now coming to the management of patients with moderate to major burns can be divided into 3 phases. This pre-hospital care, ED resuscitation and stabilization, and admission or transfer to a specialized burn center. So the basis of pre-hospital care of the burn injured patient consists of the following. That is, stop the burn process, assess and if necessary secure the airway, initiate fluid resuscitation, relieve pain, protect the burn wound, and transport the patient as early as possible to an appropriate facility. And on arrival in ER, we have to initially go with the assessment or the initial assessment. Obtain a directed history from the patient and also the PMS person who was accompanying the patient to determine the burning agent, and also the involvement of chemicals, the duration of exposure, and also if the injury was sustained in an open or an enclosed space. Assess for loss of consciousness, risk of blast injury from explosion, contact with electricity or other trauma. Assess the adequacy of or need for cervical immobilization. Also obtain the general history including the past medical and surgical history, chronic diseases, allergies, medications, and also tetanus immunization status. Quickly assess the patient's respiration, circulation, and initiate stabilization. Examine the patient for signs of inhalation injury as evidenced by respiratory distress, facial burns, carbonaceous sputum, thin nasal hair, and also soot in the mouth. If there is any evidence of airway compromise with swelling of neck, burns inside the mouth, or wheezing, perform an early endotracheal intubation. Assess the adequacy of circulation by noting the blood pressure, pulse rate, capillary refill time, mental status of the patient, and urinary output. And also keep in mind that due to the catecholamine release during a burn injury, the heart rate of 100 to 120 beats per minute is acceptable as a normal range for adults. Insert IV lines in unburned areas whenever possible, and if it is not possible, go for a burned area and start resuscitation as early as possible according to the fluid resuscitation formula. During the secondary examination, perform a head-to-toe assessment including the examination of the eye for corneal burns. Estimate and record the size and depth of the burn injury, and in patients with partial thickness burns more than 20% of body surface area, nasogastric tube insertion may be required due to frequent development of ileus. And insert a urinary catheter to measure the urinary output and also to prevent urinary retention in patients with perineal burns. Routine lab tests including a CBC and measurement of electrolyte, blood urine nitrogen, creatinine and glucose levels should be performed. In patients with moderate or severe burns or suspected inhalation injury, obtain an ABG, carboxyhemoglobin levels, serum creatine kinase, urine analysis for myoglobin, chest X-ray and also an ECG. Fiberoptic bronchoscopy is indicated in suspected inhalation injury and in intubated patients for both diagnostic and therapeutic purposes. Additional radiographs should be taken as indicated for other suspected trauma, which should not be missed. Treat suspected inhalation injury with humidified 100% oxygen, intubation and ventilation, bronchodilators, lung protective ventilator settings, and aggressive pulmonary toilet. Hyperbaric oxygen may be required for severe carbon monoxide poisoning. Burn injury in pregnant women is associated with significant morbidity to mother and child. The outcome of pregnancy may be determined by the extent of the injury to the mother, and spontaneous termination of pregnancy is common in large body surface area burns. Resuscitation requirements may exceed those estimated using the common guidelines, and fetal monitoring and early consultation with obstetrician and burn specialist are recommended in this kind of situations. Because the ED is primarily responsible for the initial fluid resuscitation, early discussion with a burn specialist may be helpful in avoiding under or over resuscitation. Patients with major burns can quickly receive excessive IV fluid during the pre-hospital and ED phases, particularly if there are two large bore peripheral catheters in place with fluid infusing at a wide open rate. So we have to document the total fluid infused and titrate infusion according to the patient's response. Clear documentation of fluid resuscitation should accompany all patients transferred to burn centers. Patients with thermal injury and concomitant multisystem trauma and those with inhalation injury generally require fluid resuscitation in excess of calculated needs. And burn patients with pre-existing cardiac and pulmonary disease require much greater attention to fluid management because they can easily go into fluid overload state. And monitor the fluid resuscitation closely by frequent assessment of vital status and also the cerebral and skin perfusion, pulmonary status and urinary output, as well as the hemodynamic monitoring. The urinary output should be aimed at 0.5 to 1 ml per kilogram per hour. The Baxter or the Parkland formula is likely the most widely used formula for thermal injury resuscitation, in which we calculate the total fluid requirement over a period of 24 hours by multiplying 4 ml of lactated ringer solution by the percentage of body surface area that is burned, which includes the partial and full thickness burns only, and multiplied by the patient's body weight in kilograms. And half the total amount is given over a period of 8 hours, and the remainder is given during the following 16 hours. So a total of 24-hour period we calculate this and give as 8 and 16. And although the importance of early fluid resuscitation has been supported by several clinical experience and studies, but there is no consensus exists in giving the appropriate assessment of resuscitation and its effect on outcome. But always fluid resuscitation recommended in burns patients, and the fluid resuscitation should be formulated according to the response of the patient. ATLS recommends the modified Brooks formula for fluid resuscitation in burns patient. In children who are above 4 years of age or above 25 kilograms in body weight, and in adults we use the formula 2 ml lactated ringer into total body weight in kilogram into total percentage of total body surface area, including the partial and full thickness burns. And we aim for a urinary output of 0.5 ml per kilogram per hour and or 30 to 50 ml per hour. In children who are less than 4 years of age or less than 25 kilogram body weight, and also in case of young children and infants, we use the formula 3 ml lactated ringer into total body weight in kilograms into the total surface area that is burnt. And the urinary output aim will be 1 milligram per kilogram per hour. And also in case of small children who are weighing less than 20 kg, due to their smaller glycogen stores, we have to add an extra of 5% dextrose to this maintenance fluid. so as to maintain the nutrition. So after initial evaluation and stabilizing the patient and also starting on early fluid resuscitation, we can attend to the burn wounds. So initially the wounds are best covered with a clean dry sheet, and later small burns can be covered with moist saline soaked dressing, and while the patient is awaiting for admission or transfer. And the soothing effect of the burns on cooling on the burns is most likely due to local vasoconstriction. And this local effect can stabilize the mast cells and also reduce histamine release, kinin formation, and thromboxane B2 formation. For large wounds, sterile drapes are preferred instead of saline soaked dressing, mainly due to it can actually cause hypothermia. And always consult the administering service of burn center as early as possible, and avoid use of antiseptic dressings in ED, because the admitting service will need to assess the wound prior to this. And also the wound care for transport patients should be discussed with the accepting burn center. Do not delay transfer for wound debridement. And for transport patients, the referring facility should follow the accepting regional burn center's treatment protocol if available. Patients with circumferential deep wounds of the limbs may develop compromise of distal circulation, particularly after initial resuscitation. And distal vascular status of such patients must be monitored closely, including the pulses, capillary refill time, pulse oximetry, and skin temperature. Doppler flow testing may also be useful. And if vascular compromise is evident, eschharotomy is indicated. The eschar is incised with a scalpel to the level of the subcutaneous fat on the mid-lateral portion of the limb, and using care to avoid incising the fascia or going for a fasciotomy. And elevated compartment pressures can also be clinically evident in this kind of situations. The incision may extend to the hands and fingers, and eschharotomy may provoke substantial soft tissue bleeding. If there are circumferential burns of the chest and neck, eschar may restrict ventilation, and the eschharotomy of the chest wall should be performed to allow adequate ventilation. The incisions are made on the anterior axillary line from the level of the second rib to the level of the 12th rib, and these two incisions are joined transversely so that the chest wall can expand. Burn injuries are exceedingly painful, and the superficial partial thickness burns are the most painful ones. The burn injury not only makes an otherwise already injured area and the surrounding tissue more painful, it can also cause hyperalgesia, mainly mediated by the alpha fibers. And local cooling may be soothing, but it does not provide pain control and can cause hypothermia. So additional pain management should be provided. In the acute phase, the preferred route is mostly IV. Opioids like morphine, fentanyl, and hydromorphone are the mainstay of treatment, and relatively large doses are required in the initial phase. And excellent indications like a short dose benzodiazepine can also be given to calm down the patient. Ensure adequate analgesia for the patients being discharged, and also achieving adequate pain control is required for patients being considered for discharge. Now coming to the care of minor burns. Minor burns typically qualify for ambulatory care, and they should be isolated, should not cross joints or be circumferential, and also should not meet any criteria for burn center admission. Even in patients with burn injury less than 10% of body surface area, patients who are at extremes of age, and also patients with significant comorbs, challenging social situations, or inadequate pain control may require inpatient care and possibly transfer to a burn center. Care of minor burns in discharged patients requires appropriate wound care instructions, adequate pain control, and coordination between the AD and a physician who will be following up the patient. Because burn injuries are painful, appropriate analgesia is required. And after appropriate analgesia, clean the burn wound with mild soap and water or dilute antiseptic solution. Debride ruptured blisters, and also debride large intact blisters or those over very mobile joints. Small blisters can be left intact in the normal mobile areas. Tetanus immunization status should be assessed, and toxoid and sometimes immunoglobulin should also be administration as required. Topical antibiotics, including antiseptics or antibiotics, play an important role in reducing the bacterial colonization and enhancing the rate of healing in burns. A wide variety of topical agents and specialized dressings are commonly used for minor burns. A mainstay of treatment has traditionally been 1% silver sulfadiazine due to its easy application and minimal toxicity. However, there are a lot of newer varieties available which have associated with better outcomes and also which require less frequent dressings. And also silver sulfadiazine is not recommended for infants who are less than 2 months of age, and also it should not be used on face because it can stain the skin grey. For the face or other small minor wounds, the recommended topical agent includes a bacitrazine or triple antibiotic like neomycin, polymyxin B, and bacitrazine zinc ointments. And the dressing should ideally be changed twice daily, gently removing the residual ointment for as long as the wound continues to weep, and then daily dressing until the healing is complete. Synthetic, occlusive, solid, or biological dressings are alternative methods for managing partial thickness burns in outpatient settings. The wounds are cleansed and debrided prior to the application of these dressings, and examples include clear occlusive synthetics, foam or hydrofibrous dressings impregnated with antiseptics, or treated biological membranes. The goal is for the dressing to act like an artificial skin, and the wound should be re-evaluated every 24 to 48 hours. The wounds treated by this kind of methods like synthetic, solid, or biological dressings are well tolerated by the patients and usually requires fewer dressing changes. And the output will be better with the wounds healing with good appearance. The only con is that this kind of dressings are much more expensive than the traditional ones. So we have to reassess the burn wounds at 24 to 48 hours for depth and extent of burn, and also explain the follow-up visit schedule and also prescribe analgesics. The discharge instruction should also include home burn care, pain control, and symptoms and signs of infection for which the patient has to come back to the hospital. Burned extremities should be elevated for 28 to 48 hours to prevent edema. Advise patients to return to the ED if there are any signs and symptoms of infection or if the pain is inadequately controlled. Patients with deep partial thickness, full thickness, and mixed thickness burns not requiring admission should be referred to a plastic surgeon or burn care specialist in 2 to 4 days for re-evaluation and consideration for skin grafting. Patients with self-inflicted wounds have additional social and psychological needs that must be addressed during their admission or prior to discharge from the ED. And they have been associated with substance abuse and also decreased likelihood of follow-up. And we have to consider psychiatric evaluation early if self-harm is suspected. Next, we will discuss about compartment syndrome. Compartment syndrome occurs when there is increased pressure within a closed space, compromising the circulation and function of the muscles and nerves within that space. It was first described in 1981 by Richard van Waxman, a German physician, who noted that there is paralysis and contracture occurring as a late sequelae of an interruption to the blood supply of the muscles supplying in the forearm. So a high degree of clinical suspicion coupled with timely surgery can be used to save the function of those muscles and nerves that are at risk of permanent damage from elevated compartment pressures. So the borders of a confined space are often made up of bone or tissue that offers minimal capacity to stretch, and any increasing in volume within that compartment results in elevated intra-compartment pressure. So in the lower extremity, the most common site is at the level of tibia and fibula, where about 40% of the compartment syndrome occurs. And the lower leg has 4 compartments, that is anterior, lateral, superficial posterior, and deep posterior. So the upper leg has 3 compartments, anterior, posterior, and medial. And due to the larger size of these compartments and the interconnectivity, they are less predisposed to having elevated tissue pressure. Because of their anatomy, the foot and buttock region of the leg also have a lower incidence of compartment syndrome. And in the upper extremity, the forearm has 3 compartments, that is flexor, extensor, and mobile ward, and these are at higher risk in the arm. The hand and the upper arm are less likely to develop a compartment syndrome. The size of the compartment increases through youth into the early adulthood, and it remains almost the same size through the subsequent years. And the amount of muscle mass in the compartment also increases during the early 20s and until it reaches about 35, after which it begins diminishing. Therefore, after the age of 35, a patient is less likely to develop compartment syndrome. Tissue perfusion is created by a gradient between the arterial pressure and the venous capillary pressure, diastolic in particular, and the ischemia occur when the tissue pressure within a compartment exceeds the venous capillary pressure. The normal pressure within a compartment is usually less than 10 millimeters of mercury, and up to 20 millimeters of mercury can be tolerated without any damage. Cell death occurs when there is prolonged exposure to elevated pressure. but the exact duration or the elevation at which a pressure becomes dangerous remains unclear. Some tissues are more resistant to ischemic damage. Bones are relatively immune to tissue pressure, but muscle tissue is rather sensitive to ischemia and nerve cells can also be easily damaged. Muscles can tolerate ischemic events that last longer than 4 hours, and greater than 12 hours of ischemia can clearly lead to cell death and long-term contracture of the extremity. And nerve cells can tolerate periods of ischemia less than 4 hours in duration, and with nerves, the ischemic insult can anything longer than 8 hours can result in neuropathy. Compartment syndrome can occur with or without trauma. For example, patients with hemophilia or rhabdomyolysis can develop compartment syndrome without any direct trauma, crush injury, or tibial fracture, and it can result in compartment syndrome to the affected extremity. In case of trauma, the symptoms are usually developed within a few hours following the injury, and the awake patient may initially complain about severe pain in the affected compartment and often refractory to even opioids. The pain is due to elevated tissue pressure within a compartment, and this pain worsens when the muscle groups within the compartment are passively or actively stretched. Young age has been shown to be the strongest predictor of developing acute compartment syndrome. The aggregation of pain by passive or active stretching of muscles in the compartment in question is the most sensitive test that we can clinical finding before the onset of ischemic dysfunction. And when nerve conduction is affected, the patient will note numbness or dysesthesia in the sensory distribution of the nerve transversing the compartment, and motor nerve function may also be affected. Because the tissue pressures do not become higher than the arterial pressure, the distal pressure in the pulse in the extremity will remain normal, and there will not be any change in the color of the warmth of the extremity. And squeezing or palpation of the muscle groups in the compartment will exacerbate pain, and firmness or fullness in the affected compartment is often detected. In the appropriate clinical setting, examination findings alone may be sufficient to make a diagnosis and propel the patient in a timely fashion into the operating room for surgical treatment. And at times, direct measurement of the tissue pressures in the compartment should be performed to calculate the delta pressure to confirm the diagnosis and determine the patient disposition. There are several commercial devices available for measuring the intracompartmental pressure. One of the most commonly used one is the Stryker kit, and it consists of a saline-filled syringe, a manometer, and a needle with a side port. So connect the manometer between the syringe and the needle and insert the needle into the compartment, and inject a few drops of saline to ensure that there are no air pockets and that the needle is not inserted into the tendon. And the gauge gives the pressure reading in millimeters of mercury, and check the pressures twice in each compartment. Also check the adjacent compartment pressures. Because the pressures are highest near the injured area, obtain measurements within 5 cm of a fracture site. The hands and feet have numerous compartments within them, but sometimes it can be too small to measure easily. And if compartment syndrome is suspected in the sites, some specialists may opt for surgical intervention without documentation of the elevated pressures. The precise intra-compartment pressure that should mandate surgical decompression still remains unclear. So there are two different pressure measurements that are usually used. One, only the intra-compartmental pressure as a guide, and it is clear that the pressures less than 30 require no intervention, and whereas pressures reading more than 45 requires decompression. An alternative approach is to measure the difference between the diastolic pressure and the intracompartmental pressure, and this may be particularly useful in hypertensive patients. A diastolic pressure that is 30 to 40 millimeters higher than the compartment pressure may be managed conservatively, and a difference between the diastolic pressure and the intracompartmental pressure less than 30 does not allow adequate perfusion and should be managed with fasciotomy. So in cases where compartment syndrome is less obvious, such as in patients who are obtended, continuous measurement of compartment pressures can be helpful. And one study determined that continuous intracompartmental pressure monitoring had an estimated sensitivity and specificity of 94 and 98% respectively. The anterior compartment is usually chosen for monitoring as it has the highest pressures at any given time. And continuous measurement of compartment pressures in a clinically obvious compartment syndrome is not necessary. And laboratory testing has no benefit in the setting of compartment syndrome. And at times the serum creatine phosphokinase may be elevated, as may be myoglobin levels. And urine analysis may also reveal myoglobinuria. And hemophiliacs or patients with clotting disorders needs assay for coagulation parameters and factor levels for correction. The initial medical management of these patients include prioritizing the primary survey. Immediately remove restrictive cast or dressings which alone can markedly reduce the tissue pressure. And place the affected limb at the level of the heart. Elevation higher than the heart can increase the arteriovenous pressure gradient. And hemophiliacs should have replacement of the factor levels, and also patients who are taking anticoagulants should have the reversal or factor replacement. Surgical fasciotomy reduces the intracompartmental pressure, and long incisions are necessary to reduce the pressure in the affected compartment and simultaneously incise adjacent compartments also. So tissue edema within the compartment will typically cause the muscle to bulge from the incision sites, and the wound should be initially left open with a second look procedure for debridement and possible closure scheduled within 48 to 72 hours after the initial intervention. And ideally speaking, the definitive wound closure is obtained within 7 to 10 days, which may require skin grafting. A contradiction to the fasciotomy is a missed timely diagnosis of compartment syndrome. And tissue pressures that have been elevated for more than 24 to 48 hours may have already caused permanent damage, and there is no point in opening the compartment at this point of time. When fasciotomy is performed in a timely fashion, it can prevent death of the muscle within that compartment and also the nerves that travel through it. And when delayed, permanent neuropathy and muscle death can occur. Functional impairment is unlikely when the compartment syndrome is diagnosed and treated within 6 hours of onset. And delays in diagnosis and treatment can carry not only functional implications but also medical legal ones. In a retrospective review of malpractice claims involving the compartment syndrome, increasing time from the first onset of symptoms to fasciotomy was associated with increasing indemnity payments. Admit all patients with compartment syndrome for surgical management or to an appropriate inpatient unit for serial observation and re-examination. And for patients with equivocal findings who are discharged, stress the importance of close outpatient follow-up and also immediate return to the ED for worsening pain, paresthesia, or motor dysfunction. Thank you.